A note to our listeners. This was recorded in person in February 2020, before COVID-19 made social distancing and masks necessary for public health. Hello, my name is Anthony Effinger. I'm the host of the Think Neuro podcast, and I'm here today with Dr. Verna Porter. She's the director of dementia, Alzheimer's disease, and neurocognitive disorders at Pacific Neuroscience Institute. Thanks for joining us.
Thank you so much for having me. My pleasure.
So, quick question, not so quick, but right off the bat, what is the difference between dementia and Alzheimer's disease?
That is a great question. I get asked that a lot because I think there is somewhat of a misunderstanding about those two terms, whether they're synonymous or whether they're really distinct and different. And the answer is Alzheimer's disease is a specific diagnosis. It's its own entity. It has a pathophysiology, it has certain treatments, certain characteristics that are distinct and unique to Alzheimer's. However, dementia is more of a generic term. It's a general term. We often talk about an umbrella term because it encompasses within it other forms of dementia. So there's Alzheimer's dementia, but there's also vascular dementia, dementia with Lewy bodies, Parkinson's-related dementia, etc. So it's important when we use that term dementia to distinguish what do we mean by that word, and then what specific type of dementia are we talking about. And the thing about dementia is, by definition, what it means is you have deficits, not only in memory, but in other aspects of cognition like visual spatial skills, language-based skills, executive functions, which is reasoning, judgment, problem solving, maybe even changes in mood, personality, and behavior that are all uniquely beyond normal limits. So when you think about how a person compares to their peer group, other people, their age, their gender, their educational level, we're talking about deficiencies in those areas that are beyond normal limits. That's really the definition of dementia. And then you want to talk about what is the root cause? What sort of disease process are you talking about? Are you talking about Alzheimer's disease or something else? And that's how you can begin to really understand what are the opportunities, how can you intervene, what are the treatments?
What percentage of dementia is caused by Alzheimer's?
That's a very good question. It's usually about 60 to 70% of forms of dementia are actually due to Alzheimer's disease pathology.
So that's
it's
why
the vast majority, which is interesting. And that's why so much interest and research and so on focuses on this particular diagnosis, is because it's by far and away the most prevalent form of dementia.
And that's why we tend to maybe conflate those things too.
Exactly.
Those terms, correct?
That's right. That's why oftentimes people equate the word dementia with Alzheimer's disease.
But if you do that, obviously in order to treat this properly, you need to be much more specific.
Yes.
And you need to understand what Alzheimer's is. So let's talk about what is Alzheimer's.
So Alzheimer's disease is a particular disease process in which there are pathophysiological changes that are occurring in the brain. Some of the main things that we observe in terms of what's causing the problem is the deposit of various abnormal proteins that are present within the brain in terms of extracellular deposits and also intracellular deposits. The extracellular deposits are amyloid protein or plaques that form that essentially, unfortunately, kind of gum up the works of how the nerves are talking one to the other. There are also intracellular problems with different proteins, tau, T-A-U proteins, that become abnormally phosphorylated, so they become changed and they cause this misfolded protein, which is present in the interior of the cell, which also gums up the works of the cell from an intracellular perspective.
I have to stop you and ask you
phosphorylation. So
what does that mean?
It's an abnormality that occurs. There's a change, a chemical structural change that occurs to this tau protein that it causes it to misfold or become abnormally adherent to these microtubules within the cell structure.
And we're inside the cell now.
So it's causing changes, exactly, changes within the interior of the cell. So there are these within the cell changes and these extracellular changes, both of which are interfering with the efficiency of how the brain cells are working. And ultimately what that translates into is problems with memory and thinking. And thinking, that word can be things like visual spatial skill changes or problems, executive dysfunction. So it can affect different domains of thinking and memory. So it's not just a memory problem, it's a cognitive problem.
Are the changes inside and outside the cell related?
They're caused by different particular processes, but it's all common to the pathophysiology of Alzheimer's. So when these things are occurring, it's ultimately interfering with how the cells function. And that's translating into the functional impairment that we witness in the patient. So that's the changes in memory and cognition that we see. So ultimately, these are physical structural changes that are happening, the deposit of proteins that are causing various problems within the brain and are leading to the changes that we see in the person.
Does this mean that Alzheimer's is kind of coming at us in two ways?
Well, that's a very good observation. And so that leads a little bit into some of the research that's been done, because a lot of the research is focused on the amyloid protein, the plaques, the extracellular deposits.
Outside.
Outside. And unfortunately, over the course of a decade plus, we've had literally hundreds of different experiments, different research projects that have looked at amyloid and trying to figure out, how do we remove amyloid? What can we do to minimize amyloid or the deposit of amyloid in the brain? And a lot of research intensity has focused just on that protein. What we're beginning to realize is that's only part of the story. And a lot of those particular trials, anti-amyloid trials, have been failures. And we've been seeing this a lot in the popular press, and there's been a lot of discussion about, why are all these anti-amyloid, anti-Alzheimer's drugs failing? Well, they're focused on one particular part of the story. And we're now beginning to look at things that are anti-tau, TAU, protein, and other ways that we can maybe affect this overall process, because it's ultimately probably a cascade of events that are happening. And if we don't look at sort of all the different aspects of this, we may be very much missing the boat. So we've really got to take a step back and say, are we looking at the full story here, or are we just focused on too small a part and we're not really getting at the root cause?
Is amyloid, is there an analogy you could make to that describe what, is it something that doesn't exist at all in somebody without Alzheimer's and does exist in somebody with it?
That's a very good question as well, because we all, as we age, get a certain amount of amyloid that's accumulating in our brain. So it's not truly an abnormal protein in the sense that it shouldn't be there at all. We oftentimes do get a mild accumulation of this. And it may be somewhat of a reactive protein. It may be coming in to deal with various inflammatory insults or other things that are happening in the context of an overall aging process. So just having amyloid itself is not necessarily a problem. It's not necessarily a disease. But if amyloid is deposited at an abnormal and excessive level, and I think that's the key word, an excessive level, then it becomes a pathophysiologic process. It becomes a disease process that's going to interfere with the processing of the brain. So that's really what we're looking at, is the relative amount of this particular protein that's getting deposited.
And what does it do? Can you say what it does to the neurons on the, we're talking about the outside again here.
Right.
Is there a way to just describe what it does?
Well, I mean, that's a good question. And I'm not sure that we know exactly in every conceivable way what it does. But it is laid down in a way that ultimately, again, interferes with how nerves talk. A very interesting analogy was actually put forward, and Dr. Dale Bredesen, who's a well-known practitioner in this field, has talked about the deposit of amyloid and amyloid plaques being a little bit like napalm. And it's interesting because there are all kinds of theories about what ultimately triggers Alzheimer's. Could it be an infectious agent? Could it be a toxin? Could it be various trophic factors like hormones and so on that change over time? There are a variety of theories of what may cause problems within the brain. And amyloid may actually be reactive. It may be something that is being put down, placed down in an effort to try to stop or stave off or decrease this attack on the brain that's occurring. So it may almost potentially be a byproduct of the underlying root problem that's occurring. What that is, what triggers it specifically, we don't know 100% for sure. And it's an active area of investigation. But I think it's an interesting conceptual way to look at this and to think about it, as this may be reactive. And it may be something that's happening as a consequence of the primary inciting agent, which is yet to be defined. So this is still an area of active ongoing investigation, and it's an area that we have to flesh out. But beyond that, there have been theories about toxic exposures, and that may be various environmental toxins, some of which we know about, some of which maybe we don't even yet know about. So those are other things. And then the inflammatory cascade that gets produced as a consequence of some of these insults that occur to the brain.
Like
Well, basically, like what would happen if you had an infectious agent that invaded the brain and then you try to fight it off. Much like if we get a cold or we have an infection that invades our body, our immune system mounts and it tries to get rid of that particular invader. Well, the same thing would happen in the brain. If there is something that shouldn't be there, your immune system will mount and you will ultimately try to kick it out. So that's what the immune system does. And when it functions well, everything goes well, and hopefully you get rid of that particular invader and things get back to normal. But sometimes inflammatory cascades, milieus, if you will, are set up that maybe perpetuate and sustain in a way that is not optimal, and sometimes even results in damage that's unintended.
Would that damage in this case be the amyloid accumulation?
That would be one particular,
Okay.
consequence or one particular observation that we see that may in fact be set up ultimately by that inflammatory environment. So these are all things that are active areas of investigation. There's a lot of research that's ongoing to try to understand how all these different sort of parts and pieces of the disease fit together. And we don't know for sure all the answers, but these are some of the theories and some of the ideas. And then a whole nother part of this is hormones and how hormonal support may be critical for proper brain health. Because if you consider, for example, women are disproportionately at risk for Alzheimer's, more so than men. So it begs the question, what is it about women? Why are we more predisposed to this? Is it hormonal changes? Is it something that happens in the context of menopause and aging and loss of these trophic hormonal factors? So these are all areas that we need to understand more.
What does trophic mean?
Trophic means like something that promotes growth and well-being and health of cells.
Okay. And what is the difference in incidence of Alzheimer's between men and women?
So there's about 2/3 more Alzheimer's in women than men. So we are disproportionately affected by this disease more so than men.
Okay. And that's what leads to this idea that it might be a hormonal something
Correct.
going on.
That's one theory. But there may be other factors as well that may be related to gender differences and changes. And that's what has to be defined.
Now, before we get into the first signs, I just want to jump back inside the cell for a moment and talk about tau. Is that the same? What are we talking about there? Is that, again, like just as we talked about with amyloid, is tau something that's around in everybody's brains? And is it?
Tau is around, yes,
Okay.
and it helps kind of support the infrastructure of the brain,
Okay.
the microtubules, the skeleton, if you will, within the cell. But if this particular protein changes in configuration, its overall chemical structure, then it can cause a misfolding of some of these proteins within the brain, and these microtubules begin to break down and they're not functioning as well, which can affect the intracellular environment and cause problems with cell health and well-being.
Okay.
And so it's another mechanism, different and distinct from the amyloid deposit. They may very well relate. They may have a lot of interrelationship, and we have to kind of figure out what that is.
And that's an open question right now.
That's right.
But suffice it to say, in Alzheimer's patients, you're going to see both of these.
That's right. And so one of the
Phenomena.
ways in which we look for Alzheimer's is we do amyloid imaging. This is still very much a research tool, and we're hoping that it's going to become more common in clinical care and practice. But there are images that can actually visualize the deposit of amyloid within the brain. And similarly, there are tau-related scans, tau imaging, that is also being developed as a new way of looking for some of these biomarkers of disease. So as we define these areas better and as we understand better how these tools can be utilized to figure out who does and does not have this disease, it also may be a way that we can follow forward the progress of various drugs or interventions or things that we're trying to do in a treatment sense to see how effective they are in decreasing these abnormalities that we know to be at the root cause and root core of this disease.
Does the realization that there are these two mechanisms at work here now, does that make you more optimistic about research? Is the intra inside the cell breakthroughs, that's newer research?
It's a little bit newer. So tau and understanding how tau may play a role has come about a little bit later than our primary interest and emphasis on the amyloid deposition. But we're realizing the two are critical elements, and we've got to understand both.
Yeah.
And so by not taking into account the fact that there's more than one problem here, I think we've sort of lost an opportunity to really intervene, and perhaps that's reflective of some of the failures that have happened in research. But I also want to emphasize the story may be way bigger than just these two phenomena. And so we've got to think about other factors that may be at play that may have other and differential effects on this disease. And it may not just be as simple as one or two things. There have been theories that have been put forth that maybe there are many things, dozens of things. And I think that that probably is likely the case that may be contributing to the pathophysiology of this disease. We've got to define what those are, how to intervene, how to clinically identify them, and how to basically fix or correct or reverse them. Because that's ultimately the way that either we're going to get at prevention or hopefully treatment or conceivably even cure in combination with other things.
When was the first case of Alzheimer's diagnosed? Roughly?
That's a good question. So the first case, the thing that started it was a case presentation in 1901 by a Dr. Alzheimer. So that's where we get the name from. And it was a 51-year-old female. She was institutionalized and was exhibiting some of these classic features of Alzheimer's disease. And he was observing this in a very sort of phenomenological case study sort of way, and he reported this. And so this was something that was notated to him and became Alzheimer's disease, because that's the way he described it.
And were the symptoms she was exhibiting, were they different enough from dementia to say this is not dementia? And was dementia around then? It had to have been, right?
It wasn't really in the same way that we think of it now.
Oh, interesting.
So this was one of the first ways in which dementia was being given a specific label and term. And so other things like dementia with Lewy bodies, frontotemporal dementia, these are much more contemporary terms that have come about over time. And we've realized that, again, dementia has many different subtypes, many different causes, many different and distinct pathophysiologies. But the Alzheimer's case, the first one reported, and the way in which it got its name, Alzheimer's disease, comes from that original person in 1901.
And that person was 51 years old.
Yes, 51-year-old female.
Now, isn't that that's young, isn't it?
Right, that's a good observation. That's exactly right. So Alzheimer's disease, traditionally, we think about it as being a disease of people who are older, over the age of 65. That's what we call late onset Alzheimer's disease. Early onset is under the age of 65. And we now know that there are distinct characteristics often of those two populations. Older individuals are less likely to be genetically mediated, although there are distinct genes associated with late onset Alzheimer's, like the ApoE gene, and specifically the ApoE4 allele confers an increased risk for late onset Alzheimer's disease. But then there's the early onset, which is related to other genes, presenilin genes, APP, other things. So the point is there may be distinct genetic parameters for each.
So you could have two different genetic mechanisms for so they're almost like two different diseases, no?
Well, oftentimes that's thought to be the case. They may be very distinct in their underlying genetics. It may be that there are commonalities that are shared, like the deposit of amyloid, for example, but the root cause, the thing that perpetuates it, could be very different. And that's part of the challenge of research, is to try to identify just that.
This is a really tricky disease.
It is really tricky.
For those two reasons. One, the two different cellular phenomena, and then these early and late.
And I think also a new push and emphasis in this entire field is looking at many different factors. Dale Bredesen, again, with whom I had an affiliation over at UCLA through the Mary Easton Center, his research is very intriguing, and it has at times been controversial, but I think that it's gaining a lot of interest and enthusiasm because he's taking a very broad perspective on this disease and saying, you know what? It's like 36 holes in a roof, or he's actually identified a few more factors now. But it's like many different factors, dozens of different factors. And it's like the holes in a roof. If it's raining and the rain's going through and you're not plugging all the holes, you're not going to really change the trajectory of the disease. You've got to take into account all these different factors. And there may be many, many different things. So one of his approaches is to look at a variety of different blood tests and also to characterize people extremely well in terms of their biological features, phenotypic features, genetic features, biochemical features, etc., and then begin to figure out what's abnormal, what's not, what do you need to fix, how do you do that, how do you get at that? And so this is kind of a new area within the field of Alzheimer's, is to try to understand, maybe we've been looking too narrow a view of this. Maybe we've got to broaden and consider it more globally.
Is that what was controversial about his work? What was controversial?
Well, in his particular case, a lot of the original observations, which were very intriguing, were based on case studies and relatively small numbers of individuals. But his case numbers are becoming larger and larger. And I think the challenge becomes, can we do a controlled clinical trial? And I think he and others are trying to do just that, to look at this in a more kind of scientifically rigorous way through a controlled clinical trial where we would see how people do on and off these particular protocols.
Okay. So tell me what it looks like. What should people look for if they start to suspect that they or somebody they love is developing Alzheimer's?
Very good question. So with Alzheimer's disease, again, the core of it is that this is beyond normal limits. And so a lot of people will come and they'll say, gosh, I'm misplacing my keys now and then, or sometimes I can't think of that name right away, but it'll come to me a few minutes later. A lot of that is normal aging. And if it's not interfering with your daily activities, your functions, your ability to get through kind of daily routines, chores, tasks, your work-related chores and tasks, that's most likely normal aging. But when it really begins to interfere with your ability to get through your day, and you're having trouble or interference with your job-related chores and tasks, or your interactions with your family or your social interactions, that's when it's beginning to trigger concern that this is really probably beyond normal limits and something that you need to get checked out. And we always talk about 5 different domains to think about. So in my field, it's not just memory. There's a lot of emphasis on memory and the loss of memory with Alzheimer's and with other conditions, other forms of dementia. But it oftentimes encompasses many different areas of cognition. So for example, there are visual spatial skill changes, and that can affect driving and navigation and geography, knowing how to get from point A to point B and back again, and the efficiency of doing so. There's executive functioning, which is reasoning, judgment, problem solving, abstraction, all those kinds of things that go into our daily chores and activities, and we have to be able to do those efficiently. If those aren't doing well, if we're not functioning well in those areas, it's going to cause problems, particularly in job performance. Then there's language, and language has several components. There's fluency, naming, repetition, comprehension. Ability to do all of that is really which forms the platform of how we communicate and how we speak, and how we're able to come up with the right word at the right time in the right way and formulate our phrases and thoughts and ideas. So that's another aspect. And there's mood and personality and behavior and how all of that plays in, like depression, anxiety, even sleep problems and disturbances. Those can affect the efficiency of memory and cognition.
Are those caused by, are you saying that sleep declines when Alzheimer's is present?
There can be changes in sleep, yes, that can actually predate the diagnosis. So the point being, if you're not attentive not only to memory problems, but to these other areas as well, if you're not looking for changes in other spheres of functioning and overall health and well-being, you could be missing some of the early signs and features of this particular condition.
Did we get all 5?
I think so. So memory, language, visual spatial skills, executive functions, mood, personality, and behavior.
Okay.
Those are the 5 areas.
That bears
right,
repeating.
absolutely. So again, we're assuming memory because memory is a core and clinical feature of this, but I wanted to emphasize those other areas as well, because you have to be thinking about those when you think about whether or not a person's showing signs of cognitive change that are beyond normal limits.
Sure. Now, normal limits, presumably when somebody comes in and says, hey, these things are happening, you must have a way to determine normal limits for somebody of that age.
Absolutely,
no?
Yes.
Okay.
And I think that's one of the mainstays of what I do day in and day out is I see patients who are along a wide spectrum of different concerns. Some people come in and they're worried. Well, they're aging. They've got a parent who has Alzheimer's. They're just worried about their relative predisposition. They want to get checked out and they want to be proactive and they want to know, what can I do at 45, 55, 60 to stave off or decrease the possibility that I would get this. Then I see people at the opposite end of the spectrum who clearly have abnormalities, identifiable disease, and they're wanting to know, what is this? What's my diagnosis? What can I do? What are the treatment options? How can I intervene? How can I prevent this from getting worse over time, if at all? So I see everybody kind of between those two extremes, everybody in between. So when I'm looking at somebody, I'm trying to characterize, is this normal or not? Can we get a baseline against which we can measure their progress? What is that baseline? How do we do it? And how do we look in a very sort of global way? How do I look functionally, structurally, metabolically, maybe genetically, and in other ways to really get a clear sense of where a person's at, whether it's normal aging or not, and what the underlying diagnosis may be.
So how do you do that? That's a lot of benchmarking.
It's a lot of benchmarking. It's exactly correct. And I think when you do this right, you do just that. You encompass that. And so it shouldn't be a quick in-office decision with a quick little 5-minute test upon which this kind of a diagnosis is based, because inherently that's going to be flawed and you can make mistakes. So what we try to do is we start out with sort of a basic evaluation, an in-office assessment where we gather a thorough history with the patient, ideally with an ancillary historian, so somebody else who can provide additional historical information, observation on how the person's doing.
You mean a relative or
a relative, a family member,
Yeah.
a close friend, somebody who knows them well and can really characterize whether or not they're changing or not. So that's part of it. And then we do an in-office evaluation of cognitive functioning, so screening testing. We do a good thorough physical exam, a neurological assessment. And then from there, we decide what else do we need to characterize this better. And oftentimes that entails structural imaging. I'm talking like an MRI scan of the brain that would physically, structurally look at the brain, including something called volumetric imaging, which is looking at your brain volumes versus somebody else, your age and your gender. And that's possible to do now. And that's something that gives us a sense of, is there atrophy in certain parts of the brain? Because certain disease processes may affect different parts of the brain in different ways. So if we can begin to get a sense of where are you quantitatively compared to your peer group, that could have great meaning. Plus, you can look for vascular disease or physical structural problems that you may not even know are present, in infectious processes, sinus disease, or other things that may need to be attended to as well. So that is a physical structural image of the brain that we like to get, is something like an MRI.
And so first question, how long does the evaluation you described first, how long does that take?
It takes about 60 minutes typically.
Okay, so that's the first.
That's the first kind
we're
of
going to talk to you, we're going to talk to this person, we're going to, okay,
Right.
That's 60 minutes.
Yes.
So that's a good long appointment in this day and age, especially.
And I would say it should be.
Yeah.
A good thorough assessment of memory and cognition should be at least a 60-minute initial encounter.
Okay.
So that's kind of step one, where we get sort of the lay of the land, as it were. We get
Sure.
a sense of what are the concerns, what are the problems, what's being observed, and we do a little bit of baseline testing and evaluation. And then from there, we can decide what other additional testing do we need. And again, that could include imaging like MRIs. It may include neurocognitive assessments, so very detailed multi-hour pencil and paper memory testing done with a neuropsychologist one-on-one to really dig into those 5 different domains thoroughly. It may involve additional laboratory metabolic blood work, including the possibility of genetic testing for something like the ApoE gene. And it's going to also potentially include other things that we may add on, like a sleep evaluation, a home sleep study to look for sleep apnea or sleep problems, depending on our suspicion, depending on what we find in that initial evaluation. So we tailor make it, but that's the kind of thing that oftentimes comes out of it.
And are each of these things done to determine the extent of a possible disease or the characteristic? I guess I'm trying to say, is it qualitative or quantitative?
And I would say the answer is a little bit of both.
Okay.
You're trying to not only understand what is this, what's the diagnosis, but how advanced is it? Is it mild, moderate, severe? What stage are you at? How does this compare to your peer group? How does it affect the different 5 domains that we talked about? Memory, language, visual, spatial skills, executive functions, mood, personality, behavior. How does it encompass those or involve those? So you're trying to get, again, that broad sweep of where are you at? What is it? Where is it? How is it affecting you? And what are the opportunities? So you're trying to get a very broad perspective on what you're dealing with.
Is it possible at any stage to say, okay, now we're going to go in and look and see how much amyloid or tau compounds you have in your brain?
That's a good question. And the amyloid imaging is still very much in the research stages.
It is.
We do occasionally do that clinically. It is possible to get that kind of an image, but unfortunately, no insurances are yet paying for it. We're very hopeful. There was something called the IDEAS study that was done to look at the utility of the use of amyloid imaging in a clinical setting. And the results that have been presented on that look very positive, and it looks like that will hopefully be influencing Medicare and so on in terms of payment, and other insurance companies, reimbursers who are going to be covering the cost of these sorts of things. But we don't have that as a readily available clinical tool at the moment. Tau imaging, same thing. It's very much in early research development. It's really not even something that I would send a patient for in the clinical setting as of yet.
Okay.
So amyloid imaging, it is possible. Some community centers have it. We are starting to do that in our community practice, but it's still very much a research tool.
Got it. So somebody comes in, they go through this, and you determine that they are at some stage in Alzheimer's disease. What's next?
The next step is really to figure out, what can we do? Is there anything driving this or perpetuating it that's fixable or correctable? For example, untreated or undiagnosed sleep apnea. We're realizing more and more that that may actually be a precipitant for more rapid or more progressive neurodegenerative disease expression. So if you have that and you're not treating it, it may actually increase the rate of the problem, may push the ship along, make things worse. Well, that is fixable. It's correctable. There are distinct treatments for that. So anything like that we can identify that's fixable or correctable, we want to. Or vitamin deficiencies, metabolic disturbances like thyroid problems. Some of these things are fixable and correctable. But beyond that, Alzheimer's disease inherently is a degenerative process. So there's a part of this that we can't fix or correct or reverse. But we do have symptomatic medications, things to at least slow the rate of progression. They do so modestly. They're not, unfortunately, highly effective drugs, but they do help. And so you want to get people on these conventional FDA-approved drugs as soon as possible to try to help preserve and protect function as long as we can and decrease the rate of progression. So that's kind of one step. And then beyond that, we really want to think about, what are those other issues that we can have an effect on, like diet, exercise, nutritional parameters, sleep, well-being, cognitive well-being, and also emotional well-being. If there's any depression, anxiety, stress from the diagnosis, those are all aspects and factors that we have to deal with as well.
Can we take those in pieces? Sleep, is that because sleep is healthy for the brain and helps keep the brain healthy in general? So you want to have somebody who's got disease get a lot of sleep?
For sure. I mean, that's part of it. But also we're realizing that sleep is a very restorative time. It's a time that we clear various toxins out of the brain, including, interestingly, the amyloid protein. Mm-hmm. So again, we all have this amyloid protein in our brains, and as we age, that accumulates a little bit more, and our efficiency in clearing it out diminishes with time. But if you are not getting proper sleep, and if you're not going through the typical architecture of sleep, and there are different phases and stages of sleep. If you're not doing that, exactly, like REM and non-REM and the different phases of sleep, if you don't do that efficiently and effectively, your brain doesn't have the opportunity to clear some of these toxins out in an efficient manner, and they may accumulate more rapidly, they may gum up the works and cause problems. But if we identify those sorts of things early, particularly in young people who are still working and productive and active, who are beginning to develop sleep problems, if we deal with that early, maybe we decrease the risk or the chance or the possibility of people emerging into a degenerative state.
So get good sleep.
Get good sleep. That's absolutely one of those holistic lifestyle factors that we need to be paying a lot more attention to.
And we haven't.
And we haven't up to this point.
So something's changing there, though,
better.
Right?
I think absolutely. Our sensitivity to that as being a provocative factor for neurodegenerative disease has changed a lot, even the last 5 years.
So how do you get somebody to get better sleep? If they do have sleep apnea, there are machines that can deal with that. But what other steps do you take?
Well, I think identifying if there is or is not a sleep disturbance and what's causing that. And oftentimes I will work collaboratively with a sleep medicine physician to try to understand, why are they having insomnia? Why are they having restlessness? Why are they awakening multiple times at night? Are those things fixable and correctable? So a multidisciplinary partnering an effort to enhance cognitive health and well-being is oftentimes needed. And that's one of our cardinal approaches at Pacific Brain Health, is to try to work in a collaborative, multidisciplinary way with colleagues in different areas to look at all of these different aspects. So for example, in my practice, I work with a geriatric psychiatrist. I work with a geriatrician. I work with a neuromuscular gait and balance specialist to make sure that people are physically moving and able to exercise and engage in life. I oftentimes work with a sleep doctor. And we have lots of people who work collaboratively in this type of a format to look at different aspects of the disease and make sure that we're not missing an opportunity.
And you're in the same building.
We're in the same building.
And that's a beautiful
the
thing,
amazing
right?
thing. Yes, it's a beautiful thing. It's amazing, and it allows for real-time interactions. And one thing I think that we're doing in a rather unique way that isn't done in all centers is we will sometimes couple these visits into the same day. Because these patients, they may have difficulty driving or with transportation, or if you're asking a family member to take time off of work and come in, you don't want to have people have to come for 5 different visits to see 5 different doctors. If you can do those on a single day, or maybe at least on a couple of visits rather than 5 different spread out over a long time visits, that's a victory. And that's a way of consolidating the care and making it highly efficient and focused and problem solving in the sense of getting to the end goal of what is this and what can we do about it sooner and faster and more efficiently.
Well, as somebody who's taking care of an aged mother, I thank you because that's
Right.
that's a real thing.
That's a real thing.
Yeah,
and I think
is
if we can help relieve the stress
absolutely
on
key.
families,
Yeah.
because we also think about this as a family disease. It's the patient, of course,
Yeah.
but it's a disease that unfortunately permeates the family. And it affects so many different people who are trying to help and facilitate that patient's progress through this, that we've got to be
Sure.
mindful of that and supportive of that for the family as a whole.
You mentioned diet. What do we do there?
Yes. So diet, we're learning more and more about diet and what we can do and what some of our opportunities are. I would say a very basic approach is something called the MIND diet. That's an acronym, MIND. It's kind of a modified Mediterranean type diet. It's similar a little bit, has some aspects of the DASH, DASH diet. But a lot of it is a little bit intuitive. It's, low fats, low processed foods, low cholesterol. And then looking also at things about how do we minimize excessive sugar intake and what does that look like? Certain fruits are very, very high in sugars. They may be healthy in some ways, but very, very high in sugars. So
Such
being
as?
mindful of that. Papaya and things like that can be very
Really?
high in sugars, or even watermelon. So we have to think about, what are we choosing? What types of foods? How are we utilizing them? And does it make sense? Are we optimizing brain health? And then there's also a lot of interest in ketogenic diet and intermittent fasting. But these are other areas that are being developed more. And so I often partner with a nutritionist in terms of deciding which of these different types of diets, or even theories about intermittent fasting helping and having 12 to 16 hour periods of time where you're not taking or ingesting things with calories, and whether or not that allows the body to sort of purge and clear out toxins.
Is that the idea behind fasting in this case?
Well, that's one of the ideas, and how it helps brain health and brain regeneration in terms of allowing the brain not to have a heavy glucose load, to kind of be a little bit quiescent, to allow it to regenerate and get back down to a more baseline state before the next, infusion of fuel, of glucose and so on into its system.
Is that the same idea behind limiting sugar, the glucose load to the brain?
Yes, and also sugar, of course, high intake of sugar can lead to diabetes, which becomes a vascular risk factor. We realize that minimizing vascular risk factors is extremely productive, not only in cardiovascular health, but in cerebral vascular health. And if you have good cerebral vascular health, that may help decrease the risk of degenerative disease. So these things are far more intertwined than I think we at first appreciated.
So what are some of the risk factors for Alzheimer's?
Risk factors are very interesting because some of them we believe are modifiable and some of them I think are clearly not. Like, for example, one of the biggest risk factors for Alzheimer's disease is age. This is a disease that inherently affects people as they age more than people who are younger. And we know that the majority of cases of Alzheimer's occur in people over the age of 65, not under, although we appreciate there is early onset Alzheimer's. That's a little different entity. But as age goes up, your relative risk of Alzheimer's increases. And for most people, it starts going up after the age of 65. So we can't really change that. That's an example of something that's not changeable. We also can't necessarily change our genes. We don't have gene modification or ways to really change genes. Like, for example, if you carry the ApoE4 gene, it can increase your relative risk or chance of developing Alzheimer's. It doesn't guarantee you get it, but it's a relative risk factor gene. So, for example, if you have ApoE4, which is a particular allele, a particular subtype of that gene, if you have no copies of ApoE4, you have about a 9% lifetime risk of getting Alzheimer's. If you have if you have one copy, you have about a 30% lifetime risk.
Oh my gosh.
If you have two copies, about 50%. So having that gene can notably change your relative lifetime risk of getting or developing that disease. And unfortunately, we can't change our genes.
Not yet.
But there are things that are modifiable. And those are things like diet, your nutritional intake, exercise, sleep, your psychiatric, psychological well-being. Those are things we can change. Minimizing head injury, head trauma, by wearing helmets and wearing safety belts and so on. That's something where we can decrease our relative risk or chance of having that. That's also an independent risk factor for Alzheimer's. And then vascular disease. So things like minimizing risk of diabetes, high blood pressure, high cholesterol. Anything that is not good for the heart, cardiovascular health and cerebral vascular health are intertwined. So if you do things that are good for the heart, chances are it's good for the brain. So keeping your blood pressure low, your cholesterol low, your blood sugars low, good diet and exercise, all of that is helpful for brain health. All of that's very modifiable. So there's parts that we can fix, there's parts that we can't. And if we focus on those kind of lifestyle choices that help optimize brain health as a whole, in my mind, that's the opportunity.
So there are things you can do.
Absolutely.
And it sounds to me like it's best to catch this early.
Yes. And so that's why we encourage people to come in and have these kind of conversations, not only with their primary doctors, but even with neurologists, people in their 40s, 50s, those are the people we want to begin to capture, because those are people who traditionally, even 10 years ago, may have waited until they became symptomatic before they sought out a doctor's opinion or care. And we're saying, let's back that up. Come in if you're concerned. Come in if you know you have the gene.
Yeah,
because people are doing 23andMe and other things, and they're checking, and they're finding out that they have these risk factor genes. Well, if you find out you have that, come in and be proactive and learn about what you can do, even in the 30s and 40s, as early as, the early kind of adult years, high productivity years. If you do things then, it can notably and dramatically stave off the risk of problems when you age.
And presumably if you have somebody in your family who's suffering with Alzheimer's disease, that's another.
It's definitely worthwhile to get checked out, for sure. Yes.
Because this sounds like it's the solution here is a holistic one of diet, exercise, all the things that, go into good health.
That's right. And a lot of these are rather intuitive and things that we've heard about for years, largely in the setting of cardiovascular health, heart health, but it's just as applicable for brain health.
Certainly. And that's, again, why you have to take a team approach to this, isn't it?
Yes, that's good. That's a good observation, is that it's so important to think about all these different spheres that we've been talking about. So it's important for me to partner, for example, with a psychiatrist to worry about psychosocial well-being, overall psychiatric health, how you're coping with a new diagnosis. All of that is part and parcel of brain health as well. So it's not just metabolism and structure and physical aspects. It's all the psychosocial, emotional aspects, social aspects that go into this that are so important too.
Is that what you mean by psychosocial? The
psychological, social. So for example, if we want to optimize our brain health, we want to be psychiatrically healthy. So we want to hopefully be free of mental conditions that can be treated or fixed, like depression, anxiety, things like that. You want to be psychologically resilient and healthy in terms of coping strategies, minimizing stress, making sure you're doing things for your overall well-being, getting good sleep. And then there's social health, so getting out, being interactive, kind of interfacing, if you will, with your environment and with people in an effective strategy and way that makes it meaningful. So you have purpose, you have things that you're trying to do to optimize your sense of contribution and your personal sense of well-being. These are all critical for brain health.
Would that be, say, volunteering if you're an older person who's out of the workforce, something like that?
volunteering or becoming involved in a book group or sharing your expertise in a particular area through lecture series or community-based programs, all of that is such a healthy way to not only contribute and add back to society, but also to have a sense of validation of who you are as a person and the relative contributions that people can make, particularly as they age, particularly as they get past retirement, so that they don't go into this sense of quiescence, senescence, but they go more into a sense of, I'm going to contribute, but in a different way. I'm going to add back and do things that maybe I didn't have time for when I was working or when I was younger. And now here's an opportunity for me to kind of retool and rethink about what interests me and how I can give back in a new and unique way that's challenging for me as an individual. And that's what we want to promote.
What does that socialization part do to the brain? Can you see it? What does it do to the brain to keep it healthy?
Well, I think it does a lot of things. It decreases inflammation and it decreases things that can be damaging to the brain by downregulating stress responses and stress hormones and various things that cause kind of that fight or flight response. But also, I think a personal sense of well-being can help with better sleep, which again helps clear out those toxins. It can help promote better neurogenesis. So we actually understand now that socialization can help build new nerve connections and help regenerate ones that were perhaps more quiescent, not as active. And we also know that being socially active and physically active exercise can help increase brain volume, brain health, and well-being. So interestingly, we don't have a drug that can help maintain brain volume and function and structure as well as exercise does. And most people aren't getting the recommended amount of exercise. So socialization and exercise, if you can do it in a group setting, that's kind of even better. But exercise of and within itself is particularly helpful and effective. The CDC recommends that most adults get about 150 minutes a week of moderate aerobic exercise, so about 20 to 30 minutes a day, ideally. And most people are getting way under that, if that at all. So that is an example of kind of a public health, concern that we have to educate people about the importance of that in terms of maintaining their physical health and well-being and their cognitive health and well-being.
So when I see seniors in the pool doing the water aerobics class with the teacher and there's a group, that's a good thing.
That's a great thing.
That's a great thing.
Yes.
It's exercise.
Social, get you out.
A little bit challenging.
Yes.
Mentally challenging.
Yes, okay. You're integrating with other people in your community. That's exactly what we want to see.
It's amazing that socializing can have an increase in something in brain volume.
Yes.
That's just...
Mm-hmm. That's the amazing thing, is that is what we rely on as living beings to help regenerate and restore and reconnect different parts of the brain. If we're not challenging our brain, it's just like a muscle. You use it, if you don't use it, you'll lose it. Well, the brain is a little bit the same way. If you're not using it, if you're not challenging yourself, if you're not doing new and intriguing things, you're going to lose synaptic connections, neural connections, and the brain is going to degenerate in different ways. But if you stimulate yourself and you get out and you're active in these different ways, it allows for new neurogenesis. And that's something that we didn't always appreciate. We didn't realize the brain had this level of plasticity. So this is a relatively new understanding that's evolved particularly rapidly in the past decade, extraordinarily rapidly in the past 3 to 5 years.
I've read a lot about that. Do you find people come to you who are sort of isolated and aren't making the most of, say, opportunities after being out of the workforce? And do you then, can you get them re-engaged?
That's exactly what we're trying to do, is do just that, get them re-engaged and help them to sort of redefine purpose. So as people age and as they retire, oftentimes there's a little bit of an existential crisis that happens, a redefining of who they are, what their role is, what their contributions can be, what their role in their family may be. And as people struggle with this, if they come out the other end of that with a productive sense of who they are and how to redefine and refocus, that's a win. That's positive. But sometimes there's very much a pulling back and a sense of defeat and a sense of kind of confinement, and that my world has suddenly become far narrower and smaller than it ever was. And that obviously can change viewpoints, and it can change ability to do all these things we're talking about, like get out in the community, interact, be social.
How do you do that?
So we're trying to kind of reconfigure that. Sometimes that involves social workers. Sometimes it involves good nurse practitioners with a lot of psychosocial training. Sometimes It involves just re-education of people about the value and the importance of doing this. And this is all part of the educational piece of brain health and what that means and how that carries throughout the lifespan. And it's not just something that you do in your 30s, 40s, and 50s, and it's something that you have to do throughout your life.
So how does P&I attack this uniquely?
Well, one of the unique things we're looking forward to doing very soon is what we're going to call HEAD Talks as opposed to TED Talks, and how we're going to try to, use different platforms and so on to get out and to disseminate information, doing things like podcasts, which we're doing now. These all become ways to get the word out and to help inform people about what the opportunities are. And then to formalize that education a little bit through things like these HEAD Talks, or even just one-on-one in our interactions with patients and families over time as we provide this educational piece to brain health and well-being. These are all different ways that we hope to kind of get this message out and help people understand that this is something that needs to happen. As soon as you hear it, meaning whether you're in your 30s, 40s, 50s, and especially when you're aging and as you're into the more advanced aging years, this is critical.
What are some of the topics you've thought about for HEAD Talks?
All kinds of different things.
Yeah.
And it's going to be, again, a multidisciplinary approach. Lots of different people are going to contribute to this. We're still formulating our upcoming roster of events.
Nice.
But I think it's going to be intriguing, and lots of folks are hopefully going to want to tune in and hear this.
And you have a lot of professionals and a lot of resources here.
Yes.
To tap.
Yes.
So there's going to be no shortage of material.
Not at all. Pacific Neuroscience is an amazing center with all kinds of different subspecialists. And then Pacific Brain Health has a number of different subspecialists within it, all of whom are working on the issue of how do we optimize brain health and well-being. So there's a plethora of different topics that I think we can go into and talk about, and I think we're looking to do just that.
Fantastic. What about, just to close up here, what about research?
Research is an interesting and hot area right now, and we're doing a couple of really interesting, intriguing things that I'm very excited about at Pacific Brain Health. One of the things that we've just opened is something called the Prevention Trial. That is an acronym, and it stands for Precision Recommendations for Environmental Variables, Exercise, Nutrition, and Training Interventions to Optimize Neurocognition. So how's that for a mouthful?
That's an acronym.
That's
right
an acronym. But it's a 1-year randomized controlled trial, and it's going to test the efficacy of clinical precision medicine. So looking at a variety of different factors and parameters, nutrition, exercise, diet, some of these metabolic parameters, in a very multimodal therapy program in older adults with cognitive impairment and early stages of Alzheimer's disease, to try to see how that kind of intensive intervention compares to more conventional clinical care. So what we're going to do is we're going to bring people in and we're going to characterize them biologically, cognitively, behaviorally. That's kind of our traditional, already fairly aggressive approach at Pacific Brain Health. But beyond that, we're then going to randomize half these people to get more individualized, tailored exercise, nutrition, environmental risk reduction, cognitive training programs, along with things like brain health coaching, all of which is designed to support this kind of lifestyle modification program. So we're looking to see how this multimodal approach actually works in a rigorous clinical trial to try to see if we can bend the curve, change the trajectory, and change where people are going with this disease. So that's one new, very exciting clinical trial that's open. We're enrolling folks. It's ongoing right now, and we're looking for people to participate in that.
Did you say that's 1 year?
It's a 1 year for
Okay.
each person. It's
For each
a 1
person.
year. Yes,
Okay.
that's correct. So that's
this
an
is
example.
You're really attacking using all of the tools
Yes.
in the kit and saying,
That's right.
does it help?
Does it help?
And how are you
Yes.
going to measure success?
It's measured in a variety of ways. So we're doing imaging modalities. We're doing a lot of biological modalities. I'm talking about various serum, plasma, blood labs, and so on, genetic testing. We're doing the brain imaging, we're doing amyloid imaging, MRIs, cognitive testing, psychiatric, psychological follow-up, social well-being, looking at behavioral parameters, a variety of things.
You're doing all that after a year for
each
all the
individual
subjects.
person, and we're trying to characterize it. So this is part of this idea behind precision medicine.
Yeah. This
gathering
is the
all
precision.
of this robust information about an individual and trying to, within that individual, optimize all these different parameters to try to see what the outcome will be. And supporting them through this process with things like brain health coaches, nutritionists, and people to help with the infrastructure of how do you do this and make it attainable, make it real in a sense.
How are you paying for this? This sounds like quite an undertaking. Are you?
This is a grant. This is
Okay,
supported
good.
by a grant and also some philanthropy.
Okay.
But yes, this is a well funded research trial, which is underway, and it's an example of the kind of thing we're doing through Pacific Brain
How
Health.
many subjects are you going to enroll?
This is going to be 30 and 30, so 60 total subjects, half in the control group, half in the active group.
And it's begun with
It has
some
begun.
subjects?
It is actively enrolling right now. Another really exciting
really
trial
exciting.
that is about to open is actually looking at stem cells and the potential application of stem cells to Alzheimer's disease. So this is a very hot area of research and interest. And stem cells are these, kind of pluripotent cells that can differentiate in various ways within the body.
I need you to define pluripotent.
And it has a lot of potential. It can go in different directions.
It can be one thing or another.
That's right.
Okay.
So as it divides, it can be one thing or another. And this is a multi-center randomized trial that's being done. It is placebo-controlled, so some people will get the stem cells, some people will not. And it's looking to see what happens after either a single or a double infusion dose of these human mesenchymal stem cells into the body. They're given intravenously, and how that works in terms of their effects on cognition and outcomes in patients who have mild forms of disease. How stem cells work,
I was going to ask.
we don't know for sure.
Right.
This is part of the ongoing research that is evolving in this field. But stem cells have been used with success in several different neurodegenerative conditions that have ranged from stroke to ALS, which is Lou Gehrig's disease, amyotrophic lateral sclerosis, and other conditions. And now it's being evaluated in conditions as diverse as Alzheimer's disease, Parkinson's disease, et cetera. So this is kind of one of the frontiers, if you will, of the field. And in terms of how it may work, some speculation is it could be that these cells get in and they cause release of various neurotrophic factors, so growth factors within the brain. That's possible. They may have some immunomodulatory effects within the brain, maybe decreasing that inflammatory environment that's causing part of the disease. It may be that there is some endogenous cell proliferation, so maybe it's stimulating new cell growth and generation and proliferation, or maybe even cell replacement. So it may be helping.
There could be cell replacement here.
There could be. That's a possibility. And it could also be causing increased expression of synaptic proteins. So synaptic proteins are those neurochemical neurotransmitters that help one nerve cell talk to the other. These are all theories. We don't know for sure, but these are theories about how it may be causing some of these effects that have been witnessed in these different neurodegenerative conditions.
Are the stem cells that you're using prone to or predisposed to acting in the brain?
That's right. So these are ones that we're hoping are honing to the brain and act locally within the brain. That's the theory behind this. Exactly. Yes.
Okay.
So it's just another example. And then, beyond that, we're looking at mobile technology-based aerobic exercise and memory training at home. So trying to do things in the home. A lot of what we talked about previously was coming into our center, being engaged in our cognitive fitness programs, and we actually have a cognitive fitness gym, which is very unique.
I've heard about that.
One of the first in the country, so we're very excited about that. But we also want to be able to do things, develop new programs that people can do in their own home. Because for better or for worse, not all people who have dementia are particularly mobile or able to come in or able to drive even. So we've got to, again, think outside the box and begin to expand our technologies and our services to people within their setting, within their home. So we're looking at various ways to do that. So that's just a taste of some of the things we're doing. We're also trying to gather a lot of precision medicine data on the patients that we're seeing in our clinic to try to understand, again, what things may be relevant as new novel biomarkers and what things could be helpful in detecting disease earlier, allowing earlier interventions. We're very interested in gender differences in this disease. So we're looking at women and Alzheimer's and how changes in hormones or history of number of births and that sort of thing may relate to later predisposition to Alzheimer's. So we're partnering with some of our colleagues at UCLA and other places to try to do some of these very new, novel, and unique research designs. So we're excited. It's
That's fantastic. This is all great stuff. This is great work.
A lot of stuff in the works, yes.
Good deal. All right. Dr. Porter, thank you for joining us.
Thank you. My pleasure.
Thank you.